what do you call a lower dose? 20 milligrams as opposed to 40 or 10?
A lot of times it's going to depend on the age and the size of the child that I'm seeing, where I'm going to start them at. And also, usually as I take my history, I kind of try to get a feel for how sensitive that person is to medication, because I certainly think there are some people who are generally more sensitive than others, and you know, I may have a 17-year-old that I'm going to start on, say, you know, the lowest dose. That's possible, just because they do tend to be somewhat sensitive to medications, and you know, like I said, that's something that I kind of try to get a feel for as I'm taking my history. So, yeah.
With the, you know, the decreased appetite has been kind of a big deal, and for, you know, a lot of people worry about. And I think when I was in training, I remember them saying that the studies have shown that if that has any effect on growth, that these kids tend to catch up later on in their growth. Is that still the case, or is there any more recent studies showing that that's not?
There have been some evidence in the literature that there can be, as a separate issue, decreased growth velocity, where the child may not grow as rapidly as you would necessarily anticipate. And usually when we do the drug holidays over, like taking the breaks on the weekend or over the summer or spring break or whatever, a lot of times we'll see catch-up growth. And some of the other recent studies have shown, especially with the people who are not able to take those kinds of breaks just because of the severity of their ADHD, that generally, overall, they don't typically lose very much height from what their predicted height would be, maybe only a few centimeters. And I certainly have some children that I see that have growth hormone deficiency, and I'll still put them on a stimulant, and the endocrinologists are fine with that. So, and with the suppression of appetite, you know, we'll try different things. Some of it depends on the response that the person's had to the medication. You know, if they're having a good response and it's really helping controlling their symptoms, you know, we'll try different strategies. A lot of times I'll encourage people to try to have the child on more calorically dense foods, you know, whole milk instead of skim or 2%, and adding carnation instant breakfast to add more calories. And a lot of kids like that taste of that better than they do like the Boost and Pediasure. I don't know if you guys have ever tried those, but they're not very good. So I'll have more success with the kids drinking the carnation instant breakfast added to the milk. So, and there are certainly some things that I know I do, and some of my colleagues who are child and adolescent psychiatrists will do to try to stimulate their appetite. If I have a child who's having difficulties with sleep, I may look at adding something like an antihistamine at night. There certainly are some pretty potent antihistamines that can stimulate appetite, and I've had some success with that. Or one of the other antidepressants, I have a few colleagues who use that one that can also have an appetite stimulating effect, especially, and it also tends to be fairly sedating, so it's one that they'll use, you know, if the person's having sleep problems, and so that way we can kind of address a couple different things, and we're not just using it for, you know, adding another drug to ameliorate side effects from the first drug. You know, you certainly don't want to get into
too many medicines,
chasing your tail that way.
Right,
yeah.
Right.
And polypharmacy, you know, I think the majority of us try to avoid that if we can.
Could you talk a little bit about the therapy? When the conversation arises with a parent at school, a lot of times the first thing they think of is medication. You're asking me to put my child on medication. And that's not the intent at all. But not being in the field of psychiatry, it's hard to speak to that to a parent. What types of things do you do in a therapy session with a child?
Well, unfortunately, I don't get the opportunity to do much therapy. With what I do, I primarily do medication management. When I did get to do therapy, a lot of what I did was what we call cognitive behavioral therapy, where we try to link thoughts with the behavior that the child is doing to try to get them to stop and think. And there certainly are different manualized, very structured approaches that are out there and are available for therapists to use. I think the majority of therapists, a lot of times, again, it's going to be tailored to the problem that's originally identified with the child. So, if it is impulsivity, they'll probably use a stop-think approach with them or attempt that. And if we're seeing a lot of oppositionality, then they'll probably go and try to address that piece of things. Certainly kids with ADHD, with their tendency to be rather intrusive, do tend to have problems with social interactions. So, looking at doing some social skills kinds of things. And then I think that the medication, in my personal opinion, I don't know what other people would necessarily say, I think it's not necessarily great at specifically improving organization itself. I think that's one of those symptoms that gets secondarily improved as your focus and concentration and attention improves. Then you're able to organize yourself better, but sometimes they still need to be taught those skills and how to go about organizing. So sometimes, at least I know the therapists in my practice will work with the person on improving study skills and what are helping them think through and come up with some checklists on how to organize themselves better. Back in 1999, there was a large study done by the NIMH called the MTA study, and it looked at over 500 children. I think there were 6 different centers that were involved around the country, and they looked at multiple different settings. They looked at community practice. They looked at how the medical centers do their approaches to medication. And probably one of the things that did come out of that study is that the best outcome and unlike a lot of other studies where, if you look at research, a lot of times they're going to exclude any other sort of thing that may be going on. So they want to get as pure of a population as they can. So if you're studying ADHD, you don't want to have anybody in there that has any of those other comorbidities that I talked about. This study did not do that. So it kind of gave us a more real-life type of picture of what is going to be going on with a person who's dealing with ADHD. And probably one of the biggest things that did come out of that is that the best response was with medication. The people that were getting therapy alone didn't generally do as well, unfortunately. I still encourage people, even if they're doing medication, to do therapy together with that, because other studies have shown that we can usually maintain them on lower doses of medication if they're participating in therapy. So a lot of times I'll really encourage the people that I see to participate in therapy as well, because I do tend to be a minimalist and I don't like, which may be surprising, to necessarily have people on a lot of medications. So,
would you, I didn't catch, you said you don't normally make those recommendations, but do you have a list of sources for interventions in the classroom?
I used to. I've moved offices a few times and unfortunately just moved here fairly recently, so I don't know if I could put my hands on it, but there was one that I had here fairly recently that I thought gave a really pretty good list of the interventions that a typical person with ADHD would benefit from, interventions within the classroom. Some of them included, obviously, minimizing distractions, having the person, the smaller, generally, and a lot of times, this is something that I'll hear as I peek in the history. It's like, well, when I work with them one-on-one, he's fine. And that's true. That is very true. With a child who has ADHD, if you're giving them one-on-one attention, they really don't have that opportunity necessarily to get distracted. So obviously, the smaller classroom size that we can have that child in, the better. So that's usually one of the things that you'd probably see on that list. A lot of times, they will need a little bit more time maybe processing information, so giving them more time on timed tests, things like that. So I'll see if I can't relocate that list, and I can email it to Dave and let him get it to you. But there are certainly some good lists out there.
What about adult ADHD? Do you have testing for that? Or are you very familiar with the adult?
With the adult version, since I do primarily work with kids, I don't necessarily see a lot of adults. I do see some who have ADHD. A lot of times what I'll look for, and I don't think I mentioned this earlier, but with our criteria under DSM-4, generally some of the symptoms have to have been present prior to the age of 7. Now, if you're seeing an adult who can't necessarily remember quite all the way back there, but you're still hearing about a lot of those similarities in that criteria, I certainly wouldn't necessarily hesitate to diagnose it. And there's the DSM-4 is a fairly forgiving manual, and if you can't have somebody necessarily meet all of your criteria, they generally do allow what we call a not otherwise specified modifier. So, if a lot of those symptoms are present, but I can't necessarily get it to specifically meet that, I certainly can diagnose ADHD not otherwise specified. Most of the adults that I've seen, we have been able to tease things out enough so that they do actually meet the criteria. Testing isn't something I specifically addressed necessarily. There certainly are a lot of checklists that are out there that are used. Even more specific than that, we can do things such as a TOVA test where they have to sit at a computer, and it can be a rather boring test, which is part of what we want because we want to see how they do sustain their attention with something that's a little less fun. Because a lot of times, as I'm taking in history, I'll hear, well, they can play their video games for hours. So, I don't understand. And it's like, well, if you really think about a video game, the stimuli of that video game is constantly changing. Their input is changing all the time. So, for me, that's not an accurate measure of how a person can sustain attention or not. But a TOVA test, it's, very boring. Same thing. Not exactly the same over and over, but it'll measure, and it takes a bit of a snapshot of how well a person does with sustaining their attention. So that can give us if I have somebody where, there's a little bit of a question, I might ask for that to be done. If I'm concerned about some of those other comorbidities that we talked about, I may ask for some more further in-depth psychological testing. If I do have somebody where I'm concerned about their brain, seizures, or if there's been a history of a brain injury, obviously I'm going to get a neurologist involved and maybe ask for even more specialized testing, such as neuropsychological testing, where it actually looks kind of at how the different areas of the brain kind of come together and talk to each other, so to speak. Did that answer your question?
Well, my son is 41, but he seems to have everything. But I went with him to a psychologist, and he said there are no tests for ADD. In fact, I don't even believe in it. And then later on in the conversation, he told us his daughter's on medication, his 4-year-old daughter's. But he said there's no testing tools.
There's not anything that can, in ways, right. I mean, a lot of the tests that are there are more kind of screening tests, and you have to use it in conjunction with a clinical exam and asking about symptoms. So, there's certainly not a blood test, or, I think some people were talking about, and some of this is true, there can be changes that are a little more indicative of ADHD, such as on an EEG, but by itself, it's not necessarily a diagnostic of ADHD. You have to put it together with your diagnostic interview and your clinical exam. So in that case, that's a fairly inaccurate statement, but if you have a clinical interview and you have a test that's like the TOVA test, which has been out there and around for years, where there's a certain, there's a high indicator of the potential for ADHD, then, the likelihood of it being present certainly is greater.
Yeah, he's very hyper, and he'll start everything, but maybe finish nothing. But he'll get it started. And then he is hyper, and he does
Talk a lot.
I've done some reading on children who are ADHD but not medicated, and I've read, there's so many different things out there, high protein diets, teenagers that take coffee breaks in high school, because of the caffeine to help them. What are your feelings on those in general? Have you ever seen anything that does help that's not?
Talk about the caffeine addiction and the alcoholism.
Because I've always heard, I'm a reading recovery teacher, and I've actually had, our reading recovery teacher leader who had a child who was so hyperactive that he could not remain in the seat long enough to conduct the lesson. And so she would have him drink a can of Mountain Dew prior to the lesson, and she told us, the class, that it was beneficial. I don't know. I've never tried it. I would not feel comfortable doing that without, consulting with a parent.
Right. Well, we do know.
And it also scares me because I thought if they're already not sitting in the seat, I'm afraid they'll be like hitting the ceiling or something. Is there any research that shows that those kinds of things are helpful, or is it just?
Honestly, I haven't really seen any research specifically around that. I think, caffeine falls in the class of methylxanthines, and certainly we do know that those things and caffeine can help improve concentration to a degree. So, there probably is a little bit of science behind that, but I don't think that it's actually had what we typically look for, the clinical double-blind placebo-controlled study to help back that up. And there certainly are a lot of, different anecdotal stories out there, like the gluten-free, I can't remember the other part of it, diet, that I've certainly had some parents tell me that they feel it's been very successful for their child, and without it, they wouldn't be where they are today. I guess my take on it a lot of times would be if a parent asked me about it specifically, I don't know that I would tell them, I don't know that I can make a specific recommendation to you about this. I don't necessarily have the literature to support that. Our first rule of thumb is first do no harm, so as long as it's not going to be harmful or potentially harmful, then, it may be worth a try. Because,
I read a recent article that talked about, it was a study, again, that found that like 80% of these children in the study, and I know you can twist a study to make it, appear just about any way you want to. But it was rather interesting because it talked about the 80% of these children that were tested that were they were in an ADHD group of children. The 80% of them were low in magnesium, and they said that the article said that one of the reasons is because we have so few foods in our diet that provide magnesium, and that it's a necessary nutrient for the brain to produce the chemicals for attentiveness. And it said that, like, nuts, was one of the food groups that provided magnesium, and a lot of children don't like nuts. And, of course, it suggested then that you get vitamins that are high in magnesium. And I actually have a niece that I'm concerned. She's 7, and I'm concerned that she has ADHD. So I went, to Walmart, and I looked at every single vitamin, children's vitamin, to see the daily allowance of magnesium. And, the highest was a 10% daily allowance. Most of them were 5% or less. Do you know, have you ever heard anything regarding...
You always hear a lot about different deficiencies that may be associated with the different disorders. I don't know that I've really read anything that speaks to one specifically more than another, and I think that that's going to, again, vary from individual to individual. I do certainly encourage my parents to have their children on a multivitamin to make sure that we don't have some sort of deficiency going on potentially. So, and then of course with our medications suppressing appetite, then that becomes a concern as well, which is again why I'll recommend something like carnation instant breakfast, which does have some additional nutrients in it besides just adding calories. So to kind of help with that, you do first want to have the substrates there for the brain to be able to use. So that is, nutrition is an important key. So I don't know that I've necessarily seen any one thing in particular that's been singled out. So.
Is it common to have to try several different drugs before you find something that works, and what's the next step if you've tried several and not finding one?
Again, that's going to vary from person to person. I do have some where we strike it rich, so to speak, on our first try, and we do find something that works pretty well right off the bat. I will have some people where we've tried just about the whole range and gamut of things, and then if I've gone through that and maybe perhaps tried some of the medications in combination and we're still having problems, then a lot of times I'll then start to question the diagnosis and look at perhaps pursuing some further testing, either referring them for just general psychological testing versus the neuropsychological testing. Again, depending on the clinical picture that I'm seeing and some of the history that I may be getting. So that would be what would come to my mind. Yeah.
Comment in regards to caffeine. Actually, in exercise physiology, there actually is a study in regards to caffeine-naive people. At the fatigue factor, adding caffeine actually has improved performance. So.
Cognitively now, or exercise-wise?
That's exercise-wise. So
there's evidence for even a normal somebody without ADHD. One of us, that doesn't have ADHD, we take some caffeine, and it's a window. There's a window where you get a certain amount of caffeine, and it helps you focus. You get a little too much, and you're just all over. You're just shaky, and you can't focus. So, I think
your opinion in regards to, there are times, one of the therapies really is the one-on-one. Do you think there's some preconception by some of the teachers out there? I've had one speaker say that he thinks it's almost unethical not to let the teacher know that this person's now on medication. And sometimes I don't want the teacher to know they're on medications to get an unbiased opinion. So what is your opinion? Is also start from onset and ask the parent to ask the teacher 2 weeks later, what do you think?
A lot of times, I a lot of times will leave that up to the parent. Sometimes we will talk about it, and that's something that they want, where they want that unbiased feedback. I guess I don't necessarily direct people one way or the other with regards to that. Certainly, I think, if the medication's not a good fit and it worsens things, you're going to hear that right away anyway. So, a lot of times parents sometimes worry about their child being stigmatized and singled out and in the classroom. So if that's a big concern of theirs, then, I don't necessarily push them in one direction or the other.
You mentioned an antihistamine that could be an appetite stimulant.
Mm-hmm.
Could you share what one of those might be?
The one that I generally will look at using is called cyproheptadine, Periactin. It's actually used in other areas of medicine to help with stimulating appetite. So we do know it has a pretty potent effect that way. If a child has asthma, I wouldn't put them on it though, because it also has a tendency to thicken secretions, so you don't want to do that. So again, you have to kind of take all aspects into consideration.
Kind of along that same line, talking about antihistamines, I found it interesting. I used to be in the classroom, and now I'm a reading recovery teacher, so I worked in a group setting, and now I'm on one-to-one. But I've noticed that when children are a child who's a little bit active and moves around a lot, oftentimes when they have a cold and they're taking cold medication, they're very settled. Is that because they are not feeling well, or does the cold medication have somewhat the same effect, being a stimulant, or is it probably a combination of the two?
Most likely it's probably a combination of the two, and again, it's going to vary from person to person, because
Right.
I've really seen a lot of kids where having been on an inpatient unit and run an inpatient unit for years prior to going outpatient, a lot of times we would try antihistamines because they tend to be fairly safe if the child's really starting to get riled up, to calm them, and it can have the opposite effect with some children. So you kind of want to be a little cautious at times with it. But could there be other ingredients in there? Because a lot of the cold medicines have more than one thing in there. Generally, if there is something like pseudoephedrine in there that's sympathomimetic, a lot of times that will increase heart rate and things along those lines. So it can make the child actually more restless. So again, it can be.
It's interesting, and I'm sure it doesn't happen with all children, but I've seen it happen more than once in 20 years of teaching. That the child comes to school and mom sends a note that says, I gave them a dose of cold medicine this morning, and you see a totally different child.
And there was one class of drugs that I actually didn't touch on that I'll use, especially if hyperactivity is a big piece of things. And a lot of times I'll use this in some of the younger children, and those are the alpha agonist medications, which actually originally were manufactured to decrease blood pressure, but have been used in the field of child psychiatry for years as an intervention for ADHD, and really can be very helpful with decreasing hyperactivity. But again, because of the potential effect on blood pressure and that, you have to be pretty cautious with it. But
Is this something children outgrow, or do they carry into it?
well, again, that's going to be one of those things where it's variable. A lot of times as children grow and mature, you will see some of the symptoms gradually improve. I think some of that's due to maturity, including neurological maturation. But there certainly are quite a few people where a lot of the symptoms will persist into adulthood. And I think some people are better than others at developing ways to compensate for it, or even to take it and use it to their advantage, and go into a field where actually having ADHD is beneficial for them. Certainly people with ADHD have a tendency to be fairly creative kinds of people, and a lot of times they'll be able to use that to their advantage that way. I've certainly had some of my patients where, depending on what type of work they end up doing, they don't have to take medication, but if they decide to go back to school and take college courses, then they find that they need to resume medication. So again, it can be even variable that way. So. Well, thanks for having me. I really appreciate it.
Great presentation and a lot of great questions out here tonight. I appreciate that. Now, next month I have another guest speaker coming. His name is Dr. Chris Bojrab, and I think Dr. Shelton knows him and can vouch for his expertise. He's going to speak to us about sleep disorders, and I'm going to probably ask him to speak about all different types of things. So, not just as far as depression and bipolar disorder and other things, but also sleep apnea, restless leg syndrome, some of these things that I think you see these commercials for now, actually, especially restless leg syndrome. There's commercials all over, and you see little butterflies flying through the air about for medicines for sleep, and so it's in the press a lot. And I thought it might be a timely thing to talk about. So he's agreed to do that, and we'll meet up here the third Tuesday. I don't know what the date is now. I have to look ahead at the calendar, but the third Tuesday of next month. So thank you all for coming. I appreciate it, and hopefully we'll see you here next month.
Great.